Clinical case, PEEP titration using pulmonary mechanics. Case presentation. A 12-year-old male is admitted to the ICU with acute respiratory distress syndrome, ARDS, secondary to pneumonia. The patient is intubated and placed on mechanical ventilation. Initial ventilator settings include tidal volume, 6 ml/kg, predicted body weight, FiO2, 0.8, PEEP, 10 cm H2O, respiratory rate, 22 breaths/min. Initial arterial blood gas, ABG, shows pH, 7.32, PaCO2, 52 mmHg, PaO2, 58 mmHg. The PICU team decides to optimize PEEP using static compliance, C-STAT, and a lung recruitment maneuver followed by stepwise titration of PEEP. During the procedure, a quasi-static pressure volume, PV loop, is also generated to identify the lower inflection point, LIP, and upper inflection point, UIP. Procedure Data 1. Lung recruitment maneuver. PEEP is increased incrementally to 2 cm H2O while monitoring plateau pressure, PPLAT, driving pressure, and hemodynamics. After recruitment, PEEP is reduced in 2 cm H2O steps. Driving pressure is defined as the distending pressure above the applied positive end expiratory pressure, PEEP, required to generate tidal volume. The patient's hemodynamics remain stable throughout the titration. Two, static compliance, C-STAT, measurements. Three, pressure volume loop findings. PEEP 12, lower inflection point, LIP, 10 cm H2O, upper inflection point, UIP, 28 cm H2O. Quiz. Question 1. Based on the C-STAT measurements, what is the optimal PEEP for this patient? A. 8 cm H2O. B. 10 cm H2O. C. 12 cm H2O. D. 14 cm H2O. Question 1. C. 12 cm H2O. C-STAT is highest at 12 cm H2O, indicating optimal lung mechanics with minimal overdistension or alveolar collapse. Lowering PEEP further to 10 cm H2O leads to a decrease in C-STAT, suggesting alveolar collapse. Question 2. Why is the PEEP set 2 to 3 cm H2O above the collapse point? A. To improve PaO2 by increasing tidal volume. B. To prevent recollapse of alveoli after recruitment. C. To reduce driving pressure and increase respiratory rate. D. To avoid exceeding the upper inflection point. Question 2. B. To prevent recollapse of alveoli after recruitment. Setting PEEP 2-3 cm H2O above the collapse point provides a safety margin to maintain alveolar recruitment and prevent recollapse, ensuring sustained gas exchange and compliance. Question 3. What does the lower inflection point, lip, on the PV loop represent? A. The pressure at which overdistension begins. B. The critical pressure needed to prevent alveolar collapse. C. The point of maximal alveolar recruitment. D. The opening pressure for alveoli and an increase in compliance. Question 3. D. The opening pressure for alveoli and an increase in compliance. The LIP on the PV loop represents the pressure required to overcome surface tension and open alveoli, leading to increased lung compliance. Question 4. What is the clinical significance of the upper inflection point, UIP, on the PV loop? A. It marks the point of maximal alveolar recruitment. B. It represents the onset of overdistension and a decrease in compliance. C. It indicates the critical opening pressure of the lung. D. It signifies the optimal PEEP for gas exchange. Question 4. B. It represents the onset of overdistension and a decrease in compliance. The UIP marks the point at which further increases in pressure lead to overdistension, impairing compliance and increasing the risk of ventilator-induced lung injury. Clinical takeaways. 1. Static compliance, C-stat. Monitoring C-stat during PEEP titration allows the identification of optimal PEEP, balancing recruitment and overdistension. 2. Pressure volume loop. The lower inflection point, LIP, and upper inflection point, UIP, help guide safe and effective PEEP and PIP settings to maximize alveolar recruitment while avoiding overdistension. 3. Recruitment maneuvers. While useful, these should be performed cautiously to avoid hemodynamic compromise.